Hello and welcome to another exciting talk summaries, which I have promised earlier. So today I'm back again with the another exciting topic, which is acute coronary syndrome in pregnancy. Recent talk article which was released in April 2023. So I am going to summarize it for you guys, and I hope it is going to help for all upcoming MRCOG Part 2, MRCOG Part 3, as well as MRCPI candidates. So acute coronary syndrome, first of all, we need to understand that this is not any other new terminology. This is the second name, or you can say that this is the revised name for the myocardial infarction. All right. So myocardial infarction or acute coronary syndrome. So first of all, we need to understand that because we are talking about pregnancy, so we need to understand what exactly is the prevalence or incidence. So the rates of maternal acute coronary syndrome reported to between 0.6 and 10 per 100,000 pregnancies worldwide, although very less, but whenever it presents so severely and acutely. So the mortality rate is going to be between 5.1 to 11%. That's quite high, isn't it? So 2019 MBRACE reports shows that cardiovascular disease was the leading cause of maternal deaths, accounting for 17% of all maternal deaths. Ischemic heart disease was responsible for around one-fifth of those cases. So let me summarize it again in the easy words. Cardiovascular disease has been the leading cause of maternal deaths for about I think 5 or 6 years. And out of cardiovascular diseases, ischemic heart disease is also one of the important cause. So according to 2019, the report, it was one-fifth of these cases of the cardiovascular. So this is also very important to note that how we are going to diagnose and how we are going to treat myocardial infarction in pregnancy. So pregnant women are 3 to 4 times more likely to suffer ACS than age-matched non-pregnant women, and the incidence in this population is rising. So why it is rising? So let's talk about it. Risk factors. Risk factors can be categorized according to underlying pathophysiology. So it could be number one, pregnancy-associated spontaneous coronary artery disease dissection. We call it as PASCAD, which occurs more commonly in women with connective tissue disorder. The women who are having known cases of Marfan syndrome, hypertension, or family history of spontaneous coronary artery disease. Then, if they have any risk of atherometastasis like increased maternal age, obesity, smoking, diabetes, hypertension, dyslipidemia, and family or personal history of ischemic heart disease. So we can fairly imagine that all these risk factors are associated with the acute coronary syndrome. So other than pregnancy itself, factors increases thrombotic risk. We all know that pregnancy is a prothrombotic state, isn't it? So if any woman who have had thrombophilia, hypertensive disorders, blood transfusion history, infection, multiparity, or sickle cell disease along with pregnancy, so the ACS would be even more higher. So what trimester? Third trimester is more common. In addition to non-pregnant, increased thrombosis risk associated with anemia, blood transfusion, and it is probably a surrogate marker for ergometrin use, which may be more associated with spasm than either of the other etiology. So it means in all these cases, we should not be using ergometrin. I'm sure you all know that ergometrin is contraindicated in almost, the condition which can increase the stress because it's a powerful vasoconstrictor, right? So if it can cause any stress or strain to the heart, so that is not going to be used in the heart condition at all. So ACS may occur at any gestation. However, third trimester is very common. In one study, 73% cases occur during pregnancy and 27% occur in the postpartum period. So another study has shown that 38 cases occurred antenatally, 21% intrapartum, and 41% postnatally. So what is the pathophysiology? Across pregnancy, a rapidly changing maternal physiology stresses the cardiovascular system. This includes a blood volume increase of 50% with an associated 50% increase in the cardiac output. So what it will cause? So physiology is what? If cardiac output will increase, blood volume will increase, so the cardiac output will increase. Then what will happen? Basal heart rate will increase, and women often become anemic secondary to dilution, right? 32 weeks. We all know that maximum physiological hemodilution in pregnancy, right? Which can lead to anemia. And anemia can be a risk factor of prothrombotic state itself, isn't it? So what will happen is that prothrombotic risk or thromboembolism risk will increase in third trimester of pregnancy. right? And more so in the postpartum period. The woman connective tissue weakens and stretches in preparation for birth, and this includes the vasculature as well. And what it will cause? It will cause a increased demand placed on the maternal cardiovascular system, that a small reduction in coronary flow can precipitate significantly myocardial ischemia. So ACS can be split into three subgroups. Number one, STE elevation MI, non-STE elevation MI, and unstable angina, right? So STE elevation. So how do we categorize all of them? So we categorize all of them on the basis of ECG changes. Okay. So we all know that in myocardial infarction, what will happen is that STE segment of the ECG will, the rise. So if it is elevating from the baseline, it will lead to STE elevation MI. So ST elevation or new left bundle branch block, LBB on ECG within a clinical context that would fit with ACS. So how patient will present: chest pain, shortness of breath, ventricular arrhythmia. Plus hemodynamic instability and time to definitive treatment is the strongest predictor of the outcome. That's why it is said that, whenever a woman is presenting with chest pain, shortness of breath, or any early ECG changes in pregnancy, so I mean, try to investigate more and try to treat it as early as possible. Because the national targets focus around 1 hour window between ECG diagnosis and restoration of the coronary flow. If we do not restore coronary flow within 1 hour, what will happen is necrosis will occur. Okay, and then of course it will weaken the heart, and it will weaken the all the rhythm of the heart as well. Then non-ST elevation MI, this typically a more stable clinical situation, though hemodynamic instability is not uncommon. Okay, risk assessment on an individualized basis is crucial, and ECG changes may include ST depression and T wave inversion, though the ECG can be normal and cardiac biomarkers may be raised as well, right? I mean, they are not like, same, because in this we are getting STE elevation, and in here we are getting, if it is not elevation, then there is going to be depression, right? ST depression. Then third type is unstable angina. How patient will present: chest pain or shortness of breath at rest, sometimes with the same ECG changes add non-ST elevation, but without a biomarker rise. Exam question, right? In non-ST elevation, yes, we can have biomarker, the changes, right? Cardiac biomarker, CKMB, it will be raised, plus other cardiac biomarkers as well, TROP-T, TROP-I. All right. However, in unstable angina, the changes of ECG would be same, but the biomarkers are not going to be raised. Plus, patient is going to be having chest pain or SOB at rest, means in all position, right? In all situations. So stable angina typically presents as chest pain or shortness of breath that is relieved by rest with no biomarker rise, and in most cases a normal ECG as well. So we can just imagine that it is fairly clinical situation, right? Within ACS in pregnancy, several different etiologies can be evident. Prevalence rates differ between studies and are broadly accepted as estimated given the overall small case base. So historically, predominant subgroup has been, the pregnancy associated cardiovascular diseases, right? One study found that this is almost 27% in the cases and 43% in the older studies as well. So PASCAD usually occurs in the late third trimester and in the early postpartum period. The pathogenesis is not fully understood. However, we can associate increase in the hemodynamic stress at the time of labor and fragility of the vasculature across this period, right? So atherosclerosis has now overtaken PASCD as the most prevalent etiology, probably because of the rising maternal age and prevalence of the relevant comorb risk factors, right? We all know that, the many of the women are, the getting first time mom after like 30 or 35 years of age. So even the age, we have read earlier that age is going to be the the risk factor in this situation, right? So, in age we need to be the sure of that, how we are going to manage. Thrombosis and thromboembolism within otherwise normal coronary vessels account for about 10 to 20% of cases. Coronary artery spasm presents rarely at approximately 2% of ACS cases in pregnancy and is a poorly understood phenomena. It can usually be managed conservatively with medications. So how patient will present? Similarly, in pregnant and the non-pregnant population, atypical symptoms can be there. Chest or epigastric pain is very common, which radiates to the neck or arm, are typical symptoms, right? Traditionally, we all, they look for all these, the symptoms, which is radiating pain, which is radiating to the arm, okay, or the neck or jaw. All right. So women are more likely than men to describe atypical symptoms. However, non-specific pain, nausea, vomiting, and back pain also be there. There can be dyspnea, there can be hyperhidrosis or agitation. It is crucial to be aware of cognitive diagnostic bias when assessing pregnant women, as symptoms are often downplayed or dismissed on assessment. Examination may be unremarkable. Vital signs may indicate hemodynamic instability. PACD, thrombosis, coronary artery spasm are going to be STEMI and non-STEMI. Okay, only atheromatous disease may present as stable or unstable angina. I think this could be one of the single best answer, right? So rarely women may present as cardiac arrest. In this instance, patients should be managed as per maternal cardiac arrest guideline, because we all know that cardiac arrest do not have any specific guidelines in pregnancy. However, we just need to resuscitate according to the national resuscitation guidelines, right? So cardiac causes should be considered in all women presenting with cardiac arrest. Other causes of chest pain should be considered in differential diagnosis, including pulmonary embolism, aortic dissection, pneumonia, GERD, musculoskeletal pain, and anxiety. So how do you investigate? First of all, clinical sign and symptoms. So what do? We will take detailed history, we will do examination, okay? So how we are going to be suspicious of? Because on the basis of chest symptoms, on the basis of dyspnea, on the basis of non-specific symptoms as well, right? But diagnosis is often delayed. Specific investigation, first of all, is going to be ECG. Okay, ECG is going to be the prime investigation to look for any early ECG changes in pregnancy. Then we may go for chest x-ray, biomarkers, echo in the later stages, angiography, angioplasty, cardiac CT scan, cardiac MRI, CTPA, or VQ scan as well. However, these are going to be the the modalities to be used in the later stages. So ECG, we all know that this is going to be the pattern of ECG. First, we need to understand the physiology. What are the physiological changes, right? Physiological changes, reduction in PR interval, sinus tachycardia, left axis deviation, Q wave and T wave inversions in lead 2, 3 AVF, and T wave abnormalities V1, V2, and V3 can occur, anterior chest leads. Because we all know V1, V2, and AVF, they represent inferior wall, right? 3 lead 2, okay, and AVL, or if the and lead 3, inferior wall MI are very much common, all right, and then lateral and anterior leads are going to be from V1 to V6. So whenever there is going to be any change from lead V1 to V6, we are going to label them as anterior chest wall MI, right? Then lead 2 3 AVF, 2 3 AVF is going to be the inferior wall MI. One AVL is going to be the lateral wall MI. All right. So this is how we try to find out the ischemic changes in the walls of the heart as well, according to the leads, because we place leads accordingly, right? So pathological changes keeping in view of acute ACS would include ST elevation, then ST depression, or ST depression alone, or TVA inversion, or new bundle branch block. Anything can happen. So this is at least a responsibility as an OBG or OBG trainee, that we should understand that first of all normal ECG, and then at least find out the abnormal ECG, and then of course we need to take cardiologist in the loop as well, right? Because this is not our domain. However, diagnosing and immediate referral is going to be our domain at all times. Chest X-ray we may go for, but there is going to be the non-specific changes, all right? In the later stages, there can be pulmonary edema, venous congestion, pleural effusion, septal lines. To contextualize radial exposure, a chest X-ray give rise to the fetal dose of 50 milligyri. So this has been a very famous and important single best answer for the years. Biomarkers, yes, a positive troponin profile. We all are aware of, right? TROP-T, TROP-I, and all. So BNP and natriuretic pro-BNP do not typically have a role in the diagnosis of ACS, but may be useful in excluding other differential, namely cardiac failure. Because we all know that BNP and anti-BNP, we use them in the categorically to diagnose the ADH, right? So this is what we are going to talk in the next upcoming session. Echo, yeah, echo can be a rapid or non-invasive assessment like ECG. Maternal physiological changes can also be seen in the the echo, but echo is not going to be our prime modality. However, it is going to help to confirm or rule out other differential diagnoses such as pulmonary embolism and cardiomyopathy. All right, because normal echo does not exclude the presence of pulmonary embolism. This also we know, right? So what is the role of angiography and angioplasty? Yeah. For the emergent assessment of a patient with ACS, cardiac catheterization and angiography with the view of proceeding to angioplasty is the gold standard. Full stop. Right? So angiography can be diagnostic as well as therapeutic because through angiography we can go for angioplasty as well. So in the UK, this is available 24 hours a day, 365 a year basis. Arterial access to the direct imaging of the coronaries can be achieved in little as 5 minutes with immediate progression to intervention. So, question arises because this is a radiation, right? So, how it will, cause any harm to the mother or the fetus? So, fetal radiation exposure is 0.075 milligyri, right? Less than chest X-ray. The evidence repeatedly shows that ACS in pregnancy is a risk to life to the both mother and child. The emergence of radial access has further reduced the radiation to the fetus compared with the femoral access and should be the default access route for the interventional procedures. I'm sure you all know that when we do angiography, so femoral artery is going to be our, the prime artery to enter into the heart, right? Through the, the complete aortic system. So for coronary opacification, iodinated contrast agents are usually used. While these do cross the placenta, they have not been associated with any teratogenicity. So what we will do, fetal shielding with a lead apparent doesn't reduce the radiation because most fetal radiation exposure occur through scatter, right? Because the radiation, they have this propensity to scatter around. So we are not going to reduce any the exposure. However, that can be somehow psychologically the good for the woman as well as the doctor as well. CT, cardiac CT gives the radiation dose of 1 to 3 milligyri. Okay, so this is not our first modality to be used in the MI setting. However, this can be one of the, the you can say that available opportunity if at all it is there. Okay, cardiac MRI. There is no indication for the use of cardiac MRI. CTPA or BQ scan, again, in the context of ACS, there is no role. But if we think that the underlying pathology is pulmonary embolism, then yes, this is going to be our prime, the source of investigation. But again, question arises, fetal radiation exposure, exam question, right? So CTPA gives a fetal radiation of 0.06, 0.01 to 0.66 milligyri depending on the scanner and protocol, and also carries a small but significant increase, 13.6% in the maternal lifetime risk of the breast cancer above her background risk. And this has been talked in our another green top guideline, VT in pregnancy and postpartum, right? I'm sure all MRCOG candidates know about it. So management, first of all, MDT approach, right? Like I said earlier, that this is not going to be our OBG domain. However, diagnosing is, immediate referral is, of course, we are going to be in the loop with the cardiology team. So yeah, we are going to take, the multidisciplinary team approach, angiography. Not every subtype needs, the percutaneous, intervention. Typically, but if there is any atherosclerosis or thrombotic disease, all right, in that scenario we do need PCI, right? But there is no role of treating spasm or PASCD conservatively. In the pregnant population, caution should be taken because there is an increased risk of coronary artery dissection as well as a complication of PCI in this cohort, right? The higher incidence of PASCAD as an underlying pathology should warrant further caution. It should be clear that pregnancy is not a contraindicated for any percutaneous intervention, and no woman should be denied diagnostic angiography if needed subsequent intervention as well, because this is a life saving procedure. And I must say, this is the only life saving procedure in this context. In the presence of hemodynamic instability, immediate intervention is indicated. The European Society of Cardiology suggests that PCI should be delayed until after the fourth month of pregnancy, allowing as much time as possible between organogenesis and radiation exposure. Makes sense, isn't it? Because this way or that way, our prime, the concern is to protect the fetus from any radiation exposure, right? Then thrombolysis. Thrombolysis served as the historical precursor treatment to PCI and is still used globally, particularly in setting where PCI is not readily available. The risk of catastrophic bleeding with thrombolytic is not menial. It is roughly 3 times greater than therapeutic anticoagulation. So thrombolytic therapy is going to be relatively contraindicated in pregnancy because there is risk of maternal bleeding. So what it will do is that it will thrombolize the thrombus which has been clogged in the coronary vessels, right? So if it is going to do that, so the chances of maternal bleeding can be there. So even the maternal bleeding is going to be from genital tract. There can be subplacental bleeding that can lead to what? Another emergency, obstetrical emergency. And what is that? Abruption, right? So at all times, at all costs, we really don't want anything happen to mother or the baby or both, right? When used to treat pulmonary embolism, thrombolytic is associated with a 6% risk of fetal loss and 6% risk of premature delivery rate. So neither SK or the streptokinase, not recombinant tissue plasminogen activated across the placenta in significant amount. There would be no benefit from lysis in cases of the spasm because spasm needs to be relieved, right? However, thrombosis needs to be broken down. So, and in PASCAD, there is concern that thrombolytic causes direct dissection extension and vessel rupture leading to hemorrhagic cardiac tamponade. PCI is therefore favored. So we can simply say that yes, PCI is going to be the treatment of choice, which is, the angiography angioplasty. Thrombolytic we will reserve only in the cases of, if we are sure of, the thrombosis is the underlying pathology. Pharmacological therapy, you know, pharmacokinetics fluctuate in pregnancy and postpartum period. We all know. So many medications that are routinely used in cardiology in the non-pregnant population cannot be used in pregnancy because they are teratogenic. However, in acute settings, we can go for acute, the medications, rapid assessment, stabilization. All right. Then, assuming the delivery is not imminent, the treatment with loading dose of 300 milligram, subsequently 75 milligram once daily, and the therapeutic subcutaneous heparin should be started in the cases of thrombosis, right? Heparin is typically continued until the day before angiography. Thus, should angiography be available immediately, then holding of subcutaneous heparin allows for the intravenous heparin during the procedure. Because again, at all times, we really want mother to prevent from any recurring thrombosis. There is emerging evidence that clopidogrel is safe in pregnancy, another exam question. Okay, and usually this would be loaded as 600 milligram and later on 75 milligram subsequently daily. Chest pain should be treated with appropriate analgesics. Nitrates can be used if required, but we should be very cautious in usage of the nitrates, means nitroglycerin, right? GTN patches in non-pregnant individuals. We do use that. But what it will do? It will cause immediate vasodilatation, which will lead to what? Uterine hypoperfusion. Because if vessels will dilate, blood flow will be reduced. So what it will do? It will cause fetal hypoxia, right? So fetus may get compromised at any times. So we need to be very sure and very careful. In the presence of hemodynamic instability refractory to successful revascularization, then support with inotropes or mechanical augmentation may be required. I'm sure this is not something out of the box for any OBG trainee because we do see a couple of the patients in our training in our hospitals where we do see the inotropic agents like the dopamine, dobutamine, all right. So plus the medical augmentation, mechanical augmentation means the ventilation and all, right? Then how are you going to treat? Continuing medication, We can give antiplatelet therapy, right? Aspirin. We can give clopidogrel. All right. So again, it should be individualized. Secondary prevention: if a patient is having the hypertension as well, we can give beta blocker. But ARBs, AC inhibitors, are contraindicated in pregnancy. However, they can be used in postpartum period. ARBs and ARNI should be avoided in breastfeeding as well. AC inhibitors can be used. Furosemide is safe in the small doses, but again, it should be used cautiously. Thiazide diuretics, spironolactone, should not be used in pregnancy. Statins should be avoided in pregnancy. Anticoagulation, any heparin, low molecular weight heparin or unfractionated heparin is pretty safe to be used in pregnancy and postpartum. So, what about delivery? Very important question, isn't it? So, in the acute setting, decision to deliver depends on several factors. Outside of extreme circumstances, immediate delivery would rarely be recommended. At least, you should wait for 4 weeks, because the women needs to recover from acute, the trauma, acute insult to the heart. Delivery does not need to be undertaken before PCI. At least we need to do any percutaneous intervention, and then we need to go for any delivery. Plus, delivery again, if patient recovers from the acute attack, so yeah, she should wait by like 40%, the weeks of gestation, means term at least. The mode of delivery, again, the safe induction of labor is safe, vaginal delivery is safe. We can give prostaglandin E analog, prostin, propes, oxytocin we can give again, you know. However, in the unstable cardiac function, prostaglandin F alpha, such as carboprost, ergometrine, should be avoided. In the second stage, consideration should be given to allow 2 hours of the passive descent of the presenting part before commencing active pushing, as this can shorten the duration of pushing. Shortening the active second stage by performing early instrumental delivery is no longer routinely recommended, but assisted vaginal birth, means forceps or vacuum, should be utilized for routine obstetrical indication. However, in the cases of severe cardiopulmonary shock or cardiac arrest, cardiopulmonary resuscitation should take place, right? CPR. If more than 24 weeks of gestation, perimortem cesarean section should be performed if cardiovascular output is not re-established within 4 minutes. Again, neonatal support should be sought immediately. So, what is the outcome for the future pregnancies? For example, women with pre-existing ISD, a history of ACS, and those with residual cardiac function deficit should have careful preconception counseling and planning of their antenatal care to ensure the safety of the woman and her fetus. The risk of recurrence in the future pregnancy is 9%, means close to 10%, right? It could be a good single best answer. So what you will do in the next pregnancy: pre-pregnancy counseling, optimization of cardiac function, minimizing the risk factors, minimizing the risk of decompensation during any subsequent pregnancy. Medication should be subjected to ensure any teratogenic drugs, effective contraception. If we talk about effective contraception, barrier methods alone are not recommended because high failure rate. CHC, avoid. UK-MEC4, absolutely contraindicated in IST, chronic heart failure, stage 2 hypertension, right? Then systemic progesterone only contraceptives, you know, no contraindication, it means we can give them safely. Intrauterine methods, very good. But intrauterine methods means any copper IUCD, any Mirena. So what you need to do, this is an exam question as well, insert in hospital setting, because the risk of vasovagal collapse secondary to cervical stimulation at the time of insertion with residual left ventricle dysfunction can be there. Right? Makes sense, isn't it? Because whenever we are going to place any intrauterine device, so we have to put the patient into the thoracic position, we have to hold the anterior lip of cervix, and then we have to insert. So because anterior lip cervix has got the highest nerves, the nervous, you can say, the supply. Okay, so what it can cause? It can cause the reflex, the parasympathetic activity that can lead to vasovagal syncope, vasovagal collapse. Then sterilization, permanent method. So if at all we need to go for sterilization, so laparoscopy may not be possible in women with severely impaired cardiac function. Why? Because in laparoscopy, we, they inflate abdomen with cardiac carbon dioxide. So carbon dioxide increase intra-abdominal pressure will push the diaphragm up, and it can disturb the heart and the residual heart function as well. So laparoscopy is not going to be possible. So how we are going to do the sterilization? Maybe in the local anesthesia, maybe in the spinal anesthesia, right? So that can be done. Emergency contraception, LNG, ulipristal acetate, and copper IUCD all are safe. So almost three questions can be from this table, you know, and this is important: recurrence of ACS in the future pregnancy, and the how it is going to be presenting in the pregnancy, how we can diagnose, and how we can treat. So almost all these questions can be there in any setting, or because ACS is fairly common these days. All right. So as an OBG candidate, we need to understand that how a patient will present and how we are going to diagnose. Okay. So remember this thing: any woman who is presenting with chest tightening, chest pain, epigastric pain which is not relieved by any the proton pump inhibitors or any other thing, so keep this IHD, keep this myocardial infarction or acute coronary syndrome in your topmost differential diagnosis. Okay. Plus, if it is third trimester and postpartum, yes, it should be your topmost differential. All right. So thank you so much. I hope this is going to help you in your the better understanding of the acute coronary syndrome. I'll be back soon with another exciting talk article. Okay. So take good care of yourself. Bye bye.